Welcome to 7 Minute Surgery. This time we will address a critical topic, airway trauma. We will go through a quick review of basic sciences, understand how these injuries occur, how to assess rapidly and efficiently, and finally, how to manage according to an ATLS-based approach. We begin with the basics first. The anatomical components of the airway are the nasopharynx, the oropharynx. Going down, we have the laryngeal structures, the trachea, the bronchi, bronchioles, and alveoli. The functions of the airway include oxygenation, elimination of carbon dioxide, and protection of the lungs against aspiration and foreign bodies. Oxygenation is the main focus in the management of airway trauma. Next, we will focus to understand the specific mechanisms of airway injuries. Starting high up, maxillary fractures can obstruct the nasopharyngeal airway. In bilateral mandibular fractures, muscles attached to the mandibular body pull the tongue backwards, causing airway obstruction. Hyperextension injuries due to blunt trauma can cause tracheal injuries. Remember the possibility of an associated cervical spine injury in this case. Another type of airway injuries occur due to compression against the cervical spine. A concomitant esophageal injury can occur. Chest compression against the closed glottis drives high airway pressures and subsequent bowel trauma. A sudden deceleration causes injuries at fixed points like the cricoid cartilage and the carina. An expanding neck hematoma exerts progressive pressure on the trachea. Penetrating trauma drives airway laceration and air leak, evident clinically as a subcutaneous emphysema. Obstruction within the lumen of the airway can occur due to a blood clot, a vomitus, a foreign body, or broken teeth. A Glasgow Coma scale of 8 or less leads to muscle relaxation and the tongue falls backwards, leading to airway obstruction. Next, clinical assessment. The priority of airway comes after control of massive compressible external hemorrhage. Both assessment and management should be swift, as minutes without oxygen can lead to a permanent neurological injury. Assessment is basically clinical. A focused history is obtained to reveal the mechanism of injury and the patient's symptoms, and a clinical examination is performed to assess for signs of airway compromise. A normal verbal response indicates a patent airway at that moment. Inspect for maxillofacial fractures, inhalational, and laryngotracheal injuries. According to the 11th ATLS edition, these are the signs of laryngotracheal injuries. We can group them into the old style of look, listen, and feel. Dysphagia is a symptom indicative of a concomitant esophageal injury. Carefully look for open injuries and anterior neck ecchymosis. Cartilaginous asymmetry is basically a radiological finding. However, we can see distortion or loss of thyroid cartilage prominence on inspection. Another serious finding is the expanding neck hematoma. The patient's verbal response should be interpreted appropriately. Stridor like this one, this indicates partial airway obstruction. Hoarseness is another significant sign. Feel for subcutaneous papules or surgical emphysema and severe laryngeal tenderness. Next, we explore the management of airway injuries. If saturation is below 94%, oxygen is given. This is usually in combination with an oropharyngeal or nasopharyngeal airway. Airway management includes 3 approaches: basic maneuvers, upper airway devices, and if adequate oxygenation cannot be achieved, a definitive airway is indicated. Left lateral positioning plus active suctioning can help to alleviate obstruction by blood, vomitus, or foreign bodies. The jaw thrust maneuver, the mandible and subsequently the tongue are pushed forwards to obtain airway patency. There is no mention of the head tilt and chin lift maneuver in the 11th edition of the ATLS. Remember that this maneuver is not recommended with a suspected spinal injury. Upper airway devices are used in combination with a mask for oxygenation. Measurement is from the mouth to the angle of the mandible for the oropharyngeal airway and from the nostril to the tragus of the ear for the nasopharyngeal airway. Supraglottic devices like LMA, laryngeal tubes, and double looming tubes are less invasive compared to endotracheal tubes. A definitive airway means a cuffed tube inside the trachea. Care should be taken to protect the cervical spine by using manual inline stabilization. Equipment for endotracheal intubation should be prepared in advance, anticipating a difficult airway and the potential need for a surgical airway. To counteract the risk of rapid sequence intubation, intravenous fluid should be given to hypotensive patients and vasopressors should be available. Successful endotracheal intubation is confirmed by capnography, auscultation, and observation of chest rise. Capnography is a gold standard when available. A surgical airway is indicated as a rescue procedure if oxygenation is unsuccessful via the previous approaches. The so-called cannot intubate, cannot ventilate situation. It can also be a primary intervention in severe upper airway injuries. Cricothyroidotomy is performed by localizing the cricothyroid membrane below the thyroid cartilage first. Then the thyroid cartilage is stabilized and a longitudinal skin incision is made. The membrane itself is incised transversely and a size 6 endotracheal tube is inserted in an adult patient. To sum up, the mechanism dictates the structural injury and the suitable intervention. Management aims at relieving the obstruction. This can be achieved by basic maneuvers and active suctioning. A surgical airway should not be delayed when indicated, and we have only a few minutes to avoid permanent organ damage. Thank you and see you in another episode of 7-Minute Surgery.